Check, check. 1, 2. Check, check. 1, 2.
assume I'm okay to start. Great, okay. Well, welcome everyone. My name is Rich Oborn. I'm Director for the Center for Medical Cannabis at the Utah Department of Health and Human Services. And I'm here with Dr. Matt McIff. Matt can introduce himself in the second hour a little bit more, but I'm a public administrator, not a physician. This first hour, we're going to be going over just some of the basics of the medical cannabis program, and I'll highlight some things that have changed. Some of you may have come in the past because this is not the first time I've presented. What's happened is each year there are changes that lawmakers make to this law because it's an emerging field, and the federal law still is what it is. Medical cannabis is still illegal federally, and so the state of Utah has been a laboratory, for lack of a better term, for our own little medical cannabis program. Although we're similar to other states, we are different. And so we'll talk about a few of those distinguishing parts of our program here in Utah, and I'll talk about some things that have changed since last year, and then I'll make sure I leave some time for questions. But when it comes to the questions about treatment or clinical questions, Dr. Matt McIff is someone that is prepared to address those questions, and so we'll leave all those for the second hour. Great. So this just makes sure we're all on the same page as far as things go for me sharing some basics about the law. I'm not going to be comprehensive in all of the laws. Obviously, we don't have time for that. But I do want to give information that's current as of the date of this presentation. And so anyway, I hope people years from now don't refer to it, because by that time there'll likely be more changes. Anyway, but for now, it's a snapshot of where we are in the program. And then a complete copy of all the medical cannabis laws. Those can be found on the legislature's website. There's also links on our website to those that are specifically applicable to medical cannabis in Utah. And of course, I'm going to be providing general information to be helpful, but anything I share is not legal advice. And so I'm not even an attorney. So, okay. It's important to understand the Center for Medical Cannabis and its role in Utah's program. We are all about ensuring that qualifying patients are guided by trained professionals to receive access to safe and effective medical cannabis products. So one thing I'll emphasize is just guided by trained medical professionals, and that's you. So that's why I'm here, to just help educate medical providers about the legal aspects of the program. And then we contract with Matt McIff to help share information about experiences that he's had with patients and his research, his knowledge, to ensure we're helping lift the knowledge level about these products that many patients are relying on, especially for chronic pain at times. And it's true that cannabis use for recreational use is increasing. At the same time, it's increasing for medical use. So we just want to be a resource, and that's why I'm here, and that's our mission. This gives you a snapshot for where things are across the United States for medical cannabis and for recreational cannabis. Recreational is represented there in orange, and then those states that are medical only are found in green. And as you can see, we're surrounded by states that have products that are recreationally focused products. Although Arizona, Colorado, they'll make medical grade products and have some locations that are specific for those individuals that are seeking medical treatment. But often patients in states that are recreational struggle to find the products that are made for those that are treating themselves medically. They often have a challenge in finding those products because the companies focus on those patients, mostly they're recreational because they're buying more. But anyway, Utah for now is medical only. Yeah. Let's talk about that after the presentation. I'll come find you. Okay. All right. Oh, you know what? It was probably 40, and that might be, so say 40. That's it. Yeah, that makes sense. That's an easy question, and I think that, yeah, you do, because there's one more now. Yeah. Okay, thank you for bringing that up. We want to make sure that's accurate. Okay, let's see here. Yeah, medical cannabis definition. So when we talk about medical cannabis, understand that there are products that are related to medical cannabis, but we define it as such. So when we say medical cannabis, we're talking about products that have 0.3% or more THC or tetrahydrocannabinol. And THC is the component or substance in medical cannabis that is psychoactive, and it has a lot of derivatives that, you know, when you heat it up, it might change a little bit its composition, and it changes over time. If you heat it up and, you know, add things to it, obviously it can become slightly different than THC. But the key is that if there's a product that has 0.3% or more concentration of THC, that is a product that is federally illegal, and Utah has laws that allow for the sale and possession of those products despite the federal law. And as we saw before, many other states have those state laws as well. So one of the unique things about medical cannabis is those that have the 0.3% or more THC. Those are products that cannot be transported across state lines because they're federally illegal. So 100% of the product that is in Utah, sold in Utah at the licensed locations, that is all product that's been grown and manufactured, created in Utah, 100%. Now, a sister product that's similar is that you've heard about are hemp products, and hemp products are those that have the 0.3% or less THC. And unfortunately, there's not a lot of regulation over those products. Many of them are sold online, and it is the Wild West as far as often when you're purchasing those products. If there's patients that are purchasing those, it's really important that they understand where they came from, and that there's an independent party testing in a lab the contents of those products, because otherwise you don't really know what's in them. So anyway, but the medical cannabis products that are sold under the regulated program in Utah, those are all tested in labs, and patients and medical providers can have confidence in the certificates of analysis that are with those products, that they have the ingredients that they say they have. That's obviously truly really important with medicine, and that's how our program in Utah operates. Also, there's a small number of businesses that are licensed in Utah. I talked about this a little bit, but that gives you the number of licensees that have actual state regulated licenses. One critical thing to understand about Utah's program is that the Utah Department of Agriculture and Food, they play an important role along with my agency, the Utah Department of Health and Human Services. At the Department of Ag and Food, what they do is they are over all of the licensing of the cultivators and all of the manufacturers and all of the retailers or the medical cannabis pharmacies. And they also do a lot of the testing on the products as well, and they do audits on the independent testing laboratory that does some of the other testing to make sure that those tests are actually accurate. Across the U.S., a major concern is often the testing lab is in cahoots with the company selling the products or manufacturing the products, and they sometimes will unfortunately inflate the level of THC because in recreational states, that's often the part of the product that patients are placing priority on, that they're seeking as a high level of THC. And so in Utah, though, we do have the independent lab that's audited by a state agency, and then the state agency does testing as well. So that's why we have confidence in the testing that's done in Utah. Also, there's no limit to the level of THC that appears in a specific packaged product in Utah, or one piece of a gummy. That's one of the reasons for that is because we do have a medical program, and there are some patients that depend on a high dosage amount or a high potency to treat their medical condition. But there is some interest. Lawmakers have expressed some, and some individuals have expressed interest in placing a limit in some of those product categories, but to the date there has not been a bill that's passed that has done that. So you'll find limits in other states, some other states, but in Utah there's not one. There is a limit as to how much a patient can buy, how much product they can buy in bulk per a month, and I'll talk about that in a little bit. Also, a patient is always limited by whatever their medical provider may indicate in our software. Medical providers can jump in and set a limit for how much a patient purchases if they feel strongly about that limit, or they can place a limit on the type of product that a patient buys in our software. So we'll talk about that a little bit later. And also, medical cannabis products may be sold to individuals with active medical cannabis cards. And that includes minors, but to get a card if you're a minor, it requires a little more work, and we'll talk about that as well. And there are some dosage forms that are prohibited. We'll cover that in more detail later. Yeah, there's a question. Yes. Mm-hmm. Yeah. Yeah, so his question is about the challenge that other states have with the majority of the products being focused on recreational users of cannabis opposed to patients. Although those recreational states, they all have a medical program, and the products that patients buy aren't taxed. And so, but the products often cost more because they are just, there's more testing that's done to ensure that it's medical grade, right? So one of the things that they find is these patients do complain in other states that the products that are available aren't of the variety that they would like to see. They're not finding the same product every time that they go back to the dispensary, or they're finding that there's just not the variety that they're used to, or they're not finding products with low potency THC. If they're a lot of patients, if they're truly seeking and they're new to medical cannabis, they'll be looking for products that are low potency THC. And those products are sometimes the ones that are hardest to find because in a recreational state, they don't sell well. And it takes a lot to, manufacture a product and put in the resources to manufacture it. So anyway, yeah, that's just a challenge in other states. Sometimes there is in other states. That's that's been reported to me. One of the reasons why is because the products that are difficult to find, the economies of scale aren't there for the volume of product, and so they just charge more because there's not much of a demand for them, right? Because there's not as much demand. The company that manufactures those, they're not able to sell them in as much bulk as they are the recreational products. So that's one reason why they're higher priced often, but they aren't taxed in other states. It's similar to FDA products. So yeah, those are just some factors that other states are dealing with. Okay, and there's another question. Yeah. Right, and law enforcement, if you ask them, they'll tell you that even if you have a medical cannabis card, you're still illegal if you have product that's purchased outside of the state of Utah. Hemp is different. If it's lower THC level, then it's different. You can cross state lines with that, but if it's high level THC and someone goes to Nevada, they bring it here, then yeah, legally it's illegal, even if that person has a medical cannabis card. Right. Yeah, and local law agencies approach it differently. They all are a little bit different in how they approach it. Some are really strict about it, and others choose not to prosecute for some reason. But it's always a risk. If a patient is buying their product outside of Utah, bringing it in, there's a risk that law enforcement will take action if they're found to be in possession, or if it shows up in their system, right? Okay. This just gives you they are the only companies that are legally able to deliver it to patients. Yeah. So, and that's true in other states as well, not just Utah. And some states don't even allow delivery at all. But Utah started it in, let's see, early, I think it was 2023, and now there's a few companies that allow for it. They deliver statewide. You might have seen billboards where they advertise, right, that they deliver. Yeah, and they do it statewide. So it's especially helpful for those that are bedridden or that are in rural areas. Yeah. Yes, a lot. It does. Right. Yeah, and there's a lot of states that have gone forward with medical first for years, and then they've switched and gone recreational and kept their medical program, and the medical program suffers. and the number of patients decreases quite a bit. That happened in other states, and so yeah, it's unfortunate that there's less priority, but that's what happened in the market. Yeah, and you think about in a medical state like ours, it's medical only. Naturally, there will be people that have used for years recreationally that meet with a medical provider, that get a card, and that continue to use recreationally, right? So we acknowledge of course, there's going to be those individuals that do that. We hope that those individuals find resources and are able to coordinate and be transparent with the physician when they get treatment for whatever condition, that they're being transparent about drugs they're taking like marijuana, so that physician can give them the best care. But that's just a natural reality. Something else is that there's a certain population that gets a medical cannabis card but still buys on the black market, and they think that them having a card will protect them, and it won't. But it might, for a moment, make someone think, oh, they have a card, they're okay. But if they look at the product, which law enforcement has the ability to do to find out if it's actually legal, they would find that it's not. So, and you can also tell if a product is legal by just the dosage form. You're probably all familiar with a cannabis roll, or the products that have candy packaging that really, are pretending to be some product that is candy that sells really well at the candy store, and you go buy it in California, bring it in Utah, and it's like a Nerd's rope or something, right? We know that's not legal. You can't sell those type of products in Utah. But each product has a tracking number, and if it's state legal, it'll trace back to our system. So law enforcement, if they chose to, they could choose to track it back and ensure that it was actually purchased in the state legal system. Okay. Yeah, so there's 15 locations, and medical cannabis card holders can purchase those in person, or they can have it delivered to their home. And the law has also changed so that someone could actually have it delivered to their workplace as well. But if their workplace is a school or a church, there's a few, or a public park, you wouldn't be able to have it delivered there. This gives you a high-level look at what the growth of the program has looked like in the number of patients. And so as you can see, it's grown quickly. And we've got, these are the number of cards activated per month, that top line. And then the bottom in red, those are cards expired. So there have been a significant number of individuals who have gotten a card and then allowed it to expire and then never gotten another card. But some of those allow it to expire for 3 months or 2 months or whatever and then come back. But it's just important to realize that there's this trend, obviously, that this graph shows of that total number of cardholders growing over time. And so you'll see January 2025 and in April 2025 is when we hit 100,000. So right now we're just at like 100,200 or so. And then this other graph just shows brand new patients. So people that have been in the program for the absolute first time. These aren't renewals, these are brand new. So this just shows over time that number is going up and down, but there's monthly there's at least between 2,000 and 3,000 new cardholders that are joining the program. he's asked, is this growth of people, of so many people joining the program and new people over time joining it to the volume that they have, was that anticipated? Yeah. So when we estimated the growth of the program, we underestimated how quickly it would grow. It's just grown very fast. So no, we didn't estimate that it would grow as fast as it has. One factor, I think, has been the fact that there's more information about medical cannabis available and recreational cannabis across the U.S. available today. And so people, as they learn more about it, I think for good or for bad, they've felt a higher level of comfort with it over time. And there's some data that shows that that we'll talk about a little bit later. But the bottom line is that, yeah, over time, more people have had a higher level of comfort with medical cannabis, and more states have gone recreational since the beginning of our program. There's been several states that have gone from medical to recreational since we've started our program. So I think that's another factor that has led to more people feeling comfortable about our own program, is the fact that other states have gone recreational. So that hearing about that and reading about it online, people naturally they feel a higher level of comfort. But one thing that we try to do is provide evidence-based information so people can make educated decisions about the products that they use to treat their conditions, and that's why we're here. Okay. This just shows you the number of individuals in individual counties throughout the state. And so as you can see, obviously, no surprise, in the urban area of Salt Lake County, Utah County, Weber County, there's a higher number there in those areas. In Washington County, as you can see, St. George area. And then you can see by county how much is in each county. And then also the number of patients of different ages. So, as you can see, under 18, there's not many. There's a total of 37. Yeah. There's some research being done on that. There's a lot of factors that contribute to that number. And so when the research is released, I can make sure it's made public. But that's something that they're taking a look at. It takes time to do that type of research when you're trying to remove all these different factors and contributors to eliminate and try to isolate this as a contributor, right? But I know there's other states have done the analysis, and some have shown that it's gone up, and some have shown that it's gone down, or stayed the same, or not been a factor. Okay, qualifying conditions. So there's 16 qualifying conditions, and the Department of Health and Human Services does not set those. Those are set by the legislature. And here's a list of those qualifying conditions, alphabetized, and won't go through each one, but some of the most common are cancer. The most common is persistent pain. About 85% of those who receive a medical cannabis card indicate that pain is their most common or is their qualifying condition. That's what their medical provider determines as their qualifying condition. And that is defined a bit uniquely. We call it persistent pain because it's 2 weeks that is not adequately managed by conventional medications. And so I think chronic pain is either 3 or 6 months Right, that's kind of the standard, Matt, is. Yeah, right. So this is 2 weeks is what was compromised to define this qualifying condition. Yeah, okay. We've already talked about how many active card holders there are, and there's a graph that kind of shows those that are the highest number of qualifying conditions. When it comes to recommending medical providers to recommend medical cannabis, you have to be either an MD, a DO, a PA, or an APRN, or a podiatrist with a controlled substance license. And to become a recommending medical provider, there's a requirement that they all complete 4 hours of CE specific to medical cannabis through formal, or I say informal sources. The reason why is because during the last legislative session, there was a bill that made it so to meet this requirement, medical providers could do education through informal sources. And so this what you would call a formal source of education, right? It's a formal course that's available, and it's a conference, but informal sources, a lot of medical providers interpret that to be like a study of a peer-reviewed journal, consulting with a colleague who has experience recommending medical cannabis, learning about their experiences recommending and learning about treatment from them in an informal setting. That's a little tweak that just made it, I think, a little easier for medical providers to meet that requirement. And then there's just this requirement that every 2 years, if someone is participating in the program, that they would complete at least those 4 years of, or not 4 years, 4 hours of education that a medical provider would be required to complete. So, and then as far as a limit to the number of patients that a recommender could have, could certify for a medical cannabis card. The standard is 1.5% of the total number of registered medical cannabis card holders. And as of April 1, 2025, 1.5% happens to be 1,473. So that's the current limit. In July, well, actually right now, if you aren't registered in the program, you're limited to 15 patients. But in July, the law changes such that any of the MDs, DOs, PAs, or APRNs, or podiatrists in the state with a controlled substance license, they all have the same limit of the whatever is 1.5% of the total number of patients in the program. So that limit changes every quarter as more patients join the program. That limit gets higher and higher. So there's definitely, that's a law change that goes into effect in July, but it is something that impacts all medical providers in the state. They'll no longer be required to pay a fee and register with our office. They're able to participate in the program without registering, and their limit is always the same. Well, not they all have the same limit right now, and that'll change over time and be higher. And then also, if a recommending medical provider, we call them an RMP, recommending medical provider receives payment from a patient's insurance plan for services, that patient does not count toward their recommendation limit. So that's a small incentive for medical providers to not just have a sole focus of the appointment being to issue a medical cannabis card, but the focus of the appointment could be, I'm here to treat for chronic pain, and maybe a medical cannabis card is good for you, but maybe it's not, and I'm going to bill, the code of chronic pain in order to, get to bill insurance for this visit. But that's how some medical providers do it. At the beginning of the program, though, that was rare. A lot of medical providers weren't billing insurance at all. But now there's a lot more that do it. And we have a website that helps patients see which medical providers who recommend cannabis bill insurance and which ones don't, so they can use that as a factor that they apply as they decide where to go. Because some patients do have trouble finding a medical provider who's willing to recommend cannabis to them for obvious reasons. It's still a federally illegal drug, and a lot of medical providers are reluctant to be involved. Okay. One of the requirements of the recommending medical provider is that they have at least one initial face-to-face meeting with the patient. So that is something that hasn't changed, although the renewals can be done by telehealth. And there's also the requirement that the recommendation be made in the setting of a provider-patient relationship, and that there be a thorough assessment that's conducted that checks for these items. So that first step is just checking to see that they are who they say they are, that they've been issued some photo identification. They also check for contraindications of maybe other drugs, controlled substances they're taking that'll be reported in the controlled substance database. They consider the patient's qualifying condition, obviously, and then also the patient's history of substance use or opiate use disorder, and then their history of cannabis use in the past. Those are all factors that the statute mentions should be considered during that assessment. And then there's an option that the recommending medical provider has in our software to log into what we call the electronic verification system that a medical provider sets up a login for. They get in there and they can then document information about their assessment that they might want the pharmacist at the medical cannabis pharmacy to be aware of when that pharmacist meets with that patient for the first time. So that's just something that the medical provider has the option to do. They're not required to do that, but it could be just some very basic treatment information that they want that pharmacist to be aware of. Then they go in and complete the recommendation in the EVS for the patient. That means that there's a formal indication in the software that, yes, I support this patient getting medical cannabis. That is an option. Well, during Dr. McIff's presentation, he'll talk about how it should not be first-line treatment, and I don't think it should. But a medical provider, they aren't required to document in the software of the state the past treatments that this patient has used, but it would seem that would be a natural best standard that they would keep as they have their own notes inside their own software or patient chart. And Dr. McIff can talk about that, but it would seem that would be the best practice. The standard would be to document, okay, here's these other treatments they're attempting. I'll go back. I thought we did have, well, it's not required to be documented in the software, but they're considering the patient's qualifying condition, they're considering their history of substance use disorder, right, and their history of medical cannabis and controlled substance use, right, so their past medications. That is required by the statute. And then the very fact that someone is, like, for example, the qualifying conditions list, we talked about that kind of quickly, but I think it might be. So, for example, PTSD. That is not a qualifying condition unless it is being treated and monitored by a licensed mental health therapist. It's been diagnosed by a healthcare provider at the VA or a psychiatrist or like an LCSW or a psychiatric APRN, and it's documented in the patient's record. Yeah, there is, just a second. When it comes to, oh, there it is. The most common condition is persistent pain lasting longer than 2 weeks that is not adequately managed by conventional medications. So how does a medical provider know that it's not adequately managed? Well, they have to ask, what attempts have you made, right? So I understand that's not a very direct statement, but maybe we could make that a little more clear. But it is, that is one part of the statute. That's quoting the Utah's law. Yeah. Up to 1,400. Mm-hmm. Beginning in July, that's true. Right, but you do have to complete the 4 hours of education, regardless of how many you're recommending. Yeah, and it's interesting. Today we register what we call qualified medical providers, but in July, we won't call them qualified medical providers. They're just, every physician that participates in the program will be recommending medical providers or RMPs, and they can choose to set up an account in our system, so their card and that information is initially captured, that record is initially online and in our database, or they could choose to use a form that's on our website and just like literally fill out a PDF printed out form and have the patient go to a medical cannabis pharmacy and have that form given to that pharmacy, and the pharmacist there can put it into the software, so it's still tracked. So lawmakers felt very strongly we need to make this as easy as possible for medical providers to participate if they choose to, right? That's why that change was made. Yeah. Yeah, so his question is, are providers still required to put in a medication list in the EVS software when a medical cannabis recommendation is submitted? And the answer is no, that is not a requirement. At the first of the program it was, and then lawmakers wanted to relieve that a little bit, so they took that out. And it's an option still. But keep in mind that the medical provider is still required to check the controlled substance database and educate themselves about what other drugs they might be taking, regardless if it's a primary care physician or if it's someone that, if it's a clinic that specializes in medical cannabis recommendations, like some of them do, they are also required to check and see what other drugs this particular patient is using. And then they exercise their judgment. As a medical provider, do I want the pharmacist to be aware of this or not? Is it relevant? And they exercise that judgment, and they can choose to add that or not. Okay. Great. Okay. So the first bullet points talk about logging into the electronic verification system and using that to record the recommendation that a medical provider does for medical cannabis. And then, or is the option to do it initially outside of the software. If a medical provider just doesn't want to learn how to do that, that's fine, although it's easy. We always encourage them to do it and to figure that out. And we have instructions on our website how to do it easily. But if they choose, I just want to complete this form on paper, they're able to do that. There's a form I'll show you, and that's all they would need to take to the medical cannabis pharmacy. The patient would need to take there. This is what the paper form looks like, and so it's collecting the first and last name of the medical provider, the license numbers, the clinic name, telephone number. This is in case the pharmacist has some questions about anything that's been submitted. And then the qualifying condition of the patient, that's obviously required to be collected, and the name of the patient and some of the contact info of that patient. That is so the piece of paper that has the patient information that's submitted manually and with a piece of paper is able to be connected to the information in the electronic verification system in the database that the pharmacy obviously has access to, because their staff are required to connect those two and make sure that the account of that particular patient is made complete, and that they then are able to have in our software the amount of that purchased by that patient. It's still monitored over time. If it stays on paper, the software would have no clue, right? So that's why it's important that it be brought to the pharmacy and that the pharmacy actually puts it in the software. Yeah. Yeah, the lawmakers know that for some physicians, they'd prefer to do it that way, I guess. Right. I have that same thought, and I'd wish that every medical provider would just go online and do it. But it's a unique program, and lawmakers have tried to make it so if a medical provider chooses, they can just fill it out online, or not online, on paper. But it's always best if and it's more secure if it's done online. That's our preference. But lawmakers just wanted this other option to be there in case that's what a medical provider preferred. Okay, this is the process that someone goes through to get a card if they're over 21. And I won't go through detail on this, but one thing that has changed, or is changing in July, is that the cost of getting a medical cannabis card that's charged by the state of Utah is decreasing. It's going from $15 to $8. So that makes it more affordable and more impactful for obviously people that are low income. But that is something that that does not go into effect until July, but won't be long. Another change that's going into effect is for every product that's bought, there's a $3 transaction fee that is collected that helps support the costs of running the program at DHHS. And we've had a $3 transaction fee that's collected on every transaction for 5 years, and that's changing in July. It's going to be reduced from $3 to $1.50. So not a big change, but it is over time, less money that's being collected from patients to participate in the program and buy product. There is now, but beginning July, there will no longer be. Right now, we do have a fee to register in the program and then to renew, but that'll end in July. Yeah. So if that was a barrier for any providers, it shouldn't be any longer. Okay. All right, dosing guidelines. So an RMP can include in their recommendation a indication of the dosage form that they wish the medical patient to have, or that they wish for them not to have. So they can make it prescriptive where they're saying, I only want them to have this, or they can make it, I do not want them to have, for example, vaping cartridges, or I do not want them to buy unprocessed flour. They can also impact the dosage amount. They can make it so a patient during a 30-day period can only buy a certain amount of total product. And then these are optional, though. So some medical providers choose not to place a limitation, but one thing that's always true is that the pharmacist at the medical cannabis pharmacy can place a restriction if they choose to. There's not many that do, but they could. For example, I've heard of cases where an individual who's pregnant has come to purchase, and the pharmacist there said, no, sorry, no, it could impact your pregnancy, and we're not going to sell you the medical cannabis. But that's something that's obviously temporary, being pregnant, so that person could still have a card and come back after their pregnancy, and or hopefully long after, because there is evidence that it can impact breastfeeding, lactation as well. But anyway. Yeah. Right. That's a really good question. So when we compare our state to what we check for in other states, ours is a lot more rigorous of a list of contaminants, heavy metals, like for like a vaping cartridge type thing. And there's a long list of ingredients that they do check for that have been found to be harmful. And then the indication of what is in the product, there's higher requirements in Utah, more strict to say, okay, you must test for these ingredients, and when it shows up, you must indicate that it's there. But as you may know, when you do lab testing, you have to know exactly what you're looking for. And what's true with cannabinoids in medical cannabis is when you heat them up, they change, and they turn into a different derivative of THC. And it's scary when you get people that don't know what they're doing manufacturing the products. So Utah labs test for those derivatives more than other states do, and so they're able to tell, okay, this may not have THC A, but I know it has this other, or Delta 9 THC, but we know that it may not have Delta 9, but it has Delta 8 because of this test that we did for specifically Delta 8. So that's one difference, is that we're testing for those, and so the patient can know exactly what is in that product, what is it testing positive for. And I think it's the most scary when it comes to the liquid, because there's fillers that companies put in. They say, hey, this has got THC in it and these other cannabinoids, but what else is in there to make up the liquid? And that's part of what came up in the EVALI vaping crisis, is there were, I think it was vitamin E acetate that was found, and very harmful. That was black market product, but that would be something that our labs would test for and find to ensure that it's safe. But when patients buy product online out of state, that's when it gets really scary. There's a lot of companies, I think, taking advantage of people that way, where you don't know where it's coming from, but you know it's cheaper than it costs from a medical cannabis pharmacy. Yeah. There is some testing for hemp products, but yeah, well, there are testing of hemp products that are registered in Utah and that are sold in Utah. But one of the problems is the black market is ahead and they're quick and they're online and they don't care about Department of Agriculture requiring licensing and registration. They're black market, right? And they find that they can make a lot of money on the black market. So unless law enforcement catches up with them, you don't know what's in there. They're not tested. But there are hemp product companies that are legitimate and complying with the law, and their products do some testing, just not as much as the medical cannabis products do. It it does, but there's a lot we still don't know about medical cannabis and the derivatives that are created when it goes through the manufacturing process. So it's like whack-a-mole with drugs. As they heat them up, they're learning to test for new things and to put it into the lab to test for more over time because they're finding new cannabinoids. Anyway, yeah, so yeah, similar equipment and similar standards, but marijuana is a different animal because there's a lot we don't know about it. Yeah. Hmm. Right. Hmm. Yeah, and the cannabinoids have different properties, and so really important for the patient to educate themselves about where it's coming from and to avoid the black market. Although the black market is cheap, uh, it it's a risk they take. Anyway, yeah. No. Yeah, so lawmakers require that our fees be set to cover our costs as a regulator. And so there are no, and there's a few other things like we do give some money to research. The lawmakers required that we do disperse some funding for research. So there has been some of that, but excluding that, it's to cover our costs. So the $3 transaction fee, that comes right to Department of Health and Human Services. That's right now $3 of every transaction, and in July it'll be $1.50. Other states, they have much a higher percentage or amount of a tax that's collected, and then they use it for a lot of different efforts, a lot of different purposes. But in Utah, they haven't created that. It's just used to cover the cost of the program and to help with some research. Mm-hmm. Yeah. So when a patient buys a product, they are paying a $3 transaction fee to the state, and then they're paying $70 for the product. That goes to the retail company that sold it, but that retail company had to buy it from a manufacturer. Sometimes it's their own company, though, because some of them are vertically integrated. So Wholesome Co., for example, they're in West Bountiful. They have a cultivation, a processor, and a retail license. So they keep it all under their roof, but they also buy products from other manufacturers. In those cases, manufacturers are getting the money from Wholesome Co., the retailer, right? So And then the cultivators, they get their money from the manufacturers, because there's the 3 steps, and you got the plants, and so anyway, yeah, that kind of gives you the life cycle and where money is going. Yes. Yeah. Yep. Yeah. What are the benefits of buying legally? Oh, yeah. Well, one thing is that many patients have insurance, right? And so their insurance helps them buy a FDA-approved product at Walgreens, but it does not help them buy a federally illegal medical cannabis product. So that's a reality. That's a hurdle, major hurdle for low-income patients that may be able to benefit by using medical cannabis under the supervision of a physician. Until the federal law changes, likely they won't be able to apply their insurance to those purchases. So it's about half. I, that's my estimate. That's what people have told me. Yeah, half as much. Yeah. So they save quite a bit by doing it on the street, but there's the risk that they have that, they're not going to, there could be contaminants, especially if it's most scary when it's a vaping cartridge, right? Flower is a little bit different, but they can still be contaminants. But if it's a pill or something that there's been some manufacturing, you don't know what has gone into that and what standards were in place. Yeah. Yeah, yeah, it's a compromise the lawmakers made. And there are some patients with epilepsy that have seizures where we all know inhalation gets it into the system the quickest. And so if there's immediate relief that's required, that's why a patient would legitimately use inhalation as a method. But if you think about harm reduction, one option would be to get a flower and to grind it and to vaporize the flower instead of a liquid. And some say that that is medically a better way to go and a safer way to go, but you're still inhaling it, right? So, and for medical providers and patients, it's a cost-benefit analysis that they're thinking through, like, okay, you do have these episodes of a seizure, and you need immediate relief. And for some medical providers, they're willing to allow their patient to weigh that. It's like other drugs, but I can understand why it's a major concern with any type of a vaping device that's getting into the lungs. Yeah. Yeah, and when it comes down to it, Utah still requires that there be a medical provider involved, and there's a lot of trust that's given to a medical provider. And the factor here indicates that you're someone that cares and that really wants what's best for that patient. But unfortunately, there could be medical providers out there that aren't as careful and don't restrict what their patient buys, and their patient drives that process. Okay. none of them are. Yeah, the product, none are. Yeah. Okay, so this just talks about the Compassionate Use Board. If you're under 21, you go through that. And this talks about minor cards. As I was emphasizing earlier, there is such a small number of cards that are issued to minors, but there are some. Some of them deal with autism, and others, they've got just some really unique conditions that where the board, Compassionate Use Board, has said it's justified. But for a minor to get a medical cannabis, they have to be accompanied with a guardian card, and their guardian would go and purchase. Here's just some legal protections under state law that are in place. So it's, of course, completely illegal for a medical provider in the state of Utah to recommend medical cannabis. In fact, there's some protections that talk about civil or criminal liability and licensure sanctions that they're protected from those if all they're doing is recommending and meeting the state laws, right? But if laws are not followed, then here's some things that could happen. In DOPL would be the entity to take those actions. The penalty or fine, we don't have that authority. That would be something that DOPL would do. And then there's a contact list of those recommending medical providers that are willing to recommend on our website and that don't mind their name being on the website. There's some that recommend whose name are not on the website on purpose. They did not want their name on there. And we just share information that talks about the fee that they charge and whether they bill insurance or not, like I said before. This is just a list of the dosage forms that are legal in Utah and some other words that other terms that are used to describe that. And the route of administration that's legal for that dosage form. And prohibited forms, I'll just give you some examples of, this gives you some examples of what those are. And here's what's happened to patient purchases over time, the total number of sales in millions of dollars since the beginning of the program in January 2020. You can see that cartridges or pens, vaping cartridges, those began in second place, and over time, in like 2022, they overtook flower, became the highest selling product type, and now far below flower. And then there's edibles that are there in the purple. Yeah, this is Utah data. And then this talks about the limit of product that you can buy. And this is just talks about there's some patients that might believe that they should be able to buy even more than the state limit. And it's interesting, though, no one has requested this yet, but the state limit is the 113 grams of unprocessed flour, the 20 grams of THC. So that is, those are the state limits per every 28 days. And so a patient could petition to get more than that, but no one has yet. And then we've already covered this stuff. This just has a list of the locations across the state where individuals can purchase. And there must be a pharmacist on site during all business hours. Utah licensed pharmacist with a controlled substance license, right? And they can only sell cannabis products. They can't sell candy or T-shirts as well. And there's some limits on advertising. They can't offer samples, and there's some product labeling requirements. And then the pharmacy medical provider, that is the term that's used for the pharmacist at the location. It could also be a physician, but no medical cannabis pharmacies have hired a physician for that role. They've all hired pharmacists to fill that role. And one of the key roles of this pharmacist or pharmacy medical provider is that they must review every transaction that comes through. That is because it's possible that a medical provider could have placed a limit, and it's not as specific as a prescription would be. Like a limit that's placed isn't going to say this brand, but the limit could have been no vaping cartridges, right? So that pharmacist carries the responsibility of ensuring that any limits that are placed on the purchase of the product are enforced at that sale of the product, at that point of sale. And here's where you can reach us for contact information, and our website as well, where you can learn more about the program. So great questions. Thank you for bringing those up, and I do have to leave immediately after Dr. McIff's presentation, but you're welcome to email our office at this email address if you do have questions. Okay, well, we're going to go right into Matt, because I know he has a lot to share about the clinical side of things. And go for it.
Next.
Yeah, it's going to do that. Thank you.
Thanks, Rich. We've been doing these now for a couple of years. It's been fun to present with Rich. And how many of you were here last year when we presented? So several of you. That's good. Last year I got too much into the weeds, so we simplified a little bit so that we'd have time for questions, because obviously there are lots of questions, and there's a lot that I would like to talk about, but we're trying to focus it a little bit. So this presentation for me today is, we labeled it best practices. So really trying to focus on that, how to really approach patients and treat patients with this. Because as you've demonstrated with the questions, it's very complicated. This is a very complicated therapy. It's a cultivated product. It's not a mass-produced product from a single location. It's hard, and patients need your help. And the theme that I think is overwhelming, or underlying, not overwhelming, underlying is why I got into this, and that is, if we don't, somebody else will, and we're not going to like it. I want trained medical professionals to lead this effort, not follow. And that's really my story. That's why I'm here. So, again, my name is Dr. Matt McIff. I'm from St. George. I'm a family doctor in St. George. And I'm here for education. In 2018, the law was passed in Utah. In 2019, I had several of my patients. I've been down there for 15 years practicing medicine. Several of my patients were interested in cannabis therapy, and we did it together. And then in 2020, when the program officially launched with pharmacies, I had more patients approach me, and I thought, well, gosh, I better get educated. So I did the training, the 6 to 8 hour training, which was very good. And I would recommend it if you have not done the actual training, because there's just so much to learn about it. And as Rich said, there's a lot we don't know, but we do know a lot, but we want high-level evidence for recommendation, right? Our standard, we have high standards in medicine for recommending drugs, which potentially could be harmful. And we're not going to get, well, we don't have a lot of high-level evidence yet, but we do have some for cannabis, and a lot we're not going to get. It's really hard to do high-level evidence for a cultivated product to a system that's generalized. So we're going to have to make do with what we've got, and that's why we need the best people on the front lines to take charge. So that's kind of my story. Since I had so much interest and I got trained, I was vocal about it with my colleagues, and then got recommended to join with the Department of Health in Education and reviewing research. So that's my story, and being vocal was just about what I said earlier. We need to step up and lead. rather than follow. So that's a little bit about my story. Let's go on to this. And I'm going to switch. So cannabis, I'm going to do number 1, and then I want number 3 to be number 2. So as has been mentioned, cannabis is growing in Utah. Here's our data since 2002. Oh, great. And then, did I do that? All right. And as you saw earlier in the slides, the whole western United States, most of it is recreational and medicinal. We're the only one there with just a medical program. But then you've got Wyoming and Idaho that don't have anything. But it's growing in the United States generally, and in the West, and in Utah specifically. Let's see, but I want to skip ahead to the endocannabinoid system. So this is kind of the way I start with patients. You have a question? Whoa. I was going to take this because I don't hear very well, so I'm going to come closer. Oh, do I have to say that? I have no financial disclosures to disclose. I'm not affiliated with any of the pharmacies or the producers. Okay. I'm going to take that off. Is it still working? Okay, good. Okay, so the endocannabinoid system. This is really an important place to start. It's a great place to start because we're not taught in medical school about the endocannabinoid system, but we should be. Now, a brief history, again, it's beyond the scope of this class or this talk, but it behooves us to talk about just a couple of points of history, because the history of cannabis therapy is long and sordid, right? I mean, it's been in medicine for 1,000 years, right? In the United States, it has a long political history, which we're not going to get into. But all started in 1964 when, well, we know what the 60s were like. Either you lived it or you heard about it. Hebrew University, Dr. Meshulam and another doctor at Hebrew University discovered or isolated THC, and then shortly thereafter CBD. And so that initiated a lot more interest in research on the medical side about cannabis. Then let's fast forward to 1988, when an American chemist, now I can't remember his name, discovered a group of receptors in the brain, cannabinoid receptors. And that actually was pretty landmark. And for this reason, Dr. Meshulam in the Hebrew University later thought, well, the brain doesn't make receptors to plants. We don't do that. So there must be some endogenous chemicals in the brain, and there must be a reason we have that. So that sparked more research, and they found anandamide, which is analogous to THC, and 2-AG, or 2-arachidonyl glycerol. That's my tongue twister for the day, which is analogous to CBD. So these are endogenous compounds in our brain. They must have a purpose. So the endocannabinoid system then has been researched a little bit since then, and it's a wide and sprawling system. In fact, it's one of the most common receptors in the central nervous system. Now, how do we not study in medical school the most common receptor in the central nervous system? So that still blows my mind, but the endocannabinoid system, if there's one word to describe its function and purpose, it's homeostasis. That's not a test question, but it should be. That's what it's for. It's a regulatory system. Neuroprotection might be another word. And again, it's a large, sprawling system that we're still learning more and more about, but at least for our purposes, it's to achieve homeostasis or to maintain it. And so when you talk about endocannabinoid, well, when you talk about cannabis therapy with a patient, cannabis therapy is not a great therapy for any one thing. It's a kind of good therapy for lots of things, because the endocannabinoid system is a regulatory system that regulates neurotransmission and other neurotransmitters through synapses. And so it can mostly down or upregulate other signals transmission, mostly downregulate. That's why it can reduce a seizure or prevent one. That's why it can calm anxiety. It can reduce your perception of pain, maybe help you sleep. Lots of these things. So when you talk about patients, it's important to talk about, well, what are our goals of therapy? What do we want to achieve here? Because this is what it will do and this is what it won't do. And again, back to his presentation, we're in a world now where there's so much information floating around about everything. It's important to have trusted sources and to put things in perspective, and that's why we need to be educated and help patients figure this out. Because they will, when you have proponents of cannabis, they'll exaggerate everything. And when you got opponents of cannabis, they also exaggerate or use fear or whatever. And we've got to be somewhere in the middle, because again, we have to deal with it. We have no choice. It's here. It's kind of like that presentation on AI. It's here. Whether you've gotten into it or not, it's already here. So that's the main message. So when we back up and talk about indications, that's when you have that discussion. So let's back that up. So let's go back to the indications. So acute pain, yeah, it was against the recommendation of our board that the legislature added acute pain 2 years ago now. And that's another point. The legislature is going to do what they're going to do, and they're influenced by a lot of people. And we need to be one of those influences. So they will approve things with or without us. So not a great indication, acute pain, but it's legal. ALS, well, those poor people, I would do anything for those poor people. It may help with some of their muscle spasms and contractions, maybe their mood. Alzheimer's, really Alzheimer's with behavior disturbance. You know, if we really need to help calm them down, it's not going to do anything else for their disease process. Autism, same thing. We're treating behavior. We're treating outbursts, erratic behavior by downregulating and calming. Cachexia, yeah, treating nausea or stimulating appetite. I haven't found a lot of appetite stimulation with patients that I've treated, but mostly I just use a balanced approach. So when you talk about cannabis therapy, it's either THC rich, balanced, or CBD rich. Those are 3 categories. The state labeled them chemotypes 1, 2, and 3. Well, I don't like labels that don't tell you anything other than a number. So I like THC rich, balanced, which is either a 1-to-1, 1-to-2, 1-to-5, up to a 1-to-10 ratio, or 10-to-1, as it were. That's considered balanced. And then anything beyond a 1-to-10 or a 10-to-1 ratio is rich, so CBD rich. Perhaps a stronger THC rich might help more with cachexia, but mostly THC rich products are recreational. That's what they're after. Whereas balanced, much better for chronic pain, persistent pain, and then CBD rich, much better for other things, especially seizures or other things. Crohn's disease, again, probably not disease modifying, but maybe very helpful for their pain and their issues. Epilepsy, yes, it can reduce seizure well, maybe increase the threshold, but it can abate the seizure. And again, that is the only time I really recommend a vaping product. I really try to push patients to stick with edibles. They're reliable, they're controlled. They take longer, they're slow, but they're at least better measured, better controlled. HIV, same thing. There's a disease process with so many things going on, various parts of treatment. Hospice care, same thing. MS, that's probably the best. MS is probably the one we have the most evidence. In fact, we have strong evidence for cannabis in MS. Not only for the pain, but muscle spasms, contractures, things like that. Persistent nausea, yeah, persistent pain. Again, 80% or more of cannabis therapies for persistent or chronic pain. Yeah, they changed the name just so it could be between 2 weeks and 2 months. That's why it's called persistent rather than chronic. But that's the bear. That's the big one. PTSD, he described that earlier. That's complicated as far as the diagnostic process and then how to treat those patients with it, and then other rare conditions. So that's the first thing you do. Do you have an indication? And then do the risks outweigh the benefits? That's what we do with every therapy. And again, that's my approach to this is just another tool in my toolbox. This is nothing that I'm trying to be for or against. This is nothing I'm trying to promote or reduce. It's really just another thing we have to deal with, just like GLP-1 agonist, right? It's a thing we all have to deal with now. So you're asking that they've, yeah, they just keep adding them. Right. That was, yeah, so again, so like was alluded to earlier, how many people want to use it recreationally and they're using medical cannabis as a cover? Well, probably a lot, right? And at first was just for pain, but they keep adding indications. And it's up to us to decide, well, is it really for that indication? Is it just to treat their psyche and their discomfort with that condition, or is it really specific to that condition? You know, those are the questions that we ask. Most of it is just helping them cope with the condition, rather than very little of it is disease modifying. Because again, this system doesn't have a specific purpose. It's a regulatory system. So that's why we have to teach patients that. Well, this isn't going to do what you read online. It's just going to help you deal with it. It's going to help you cope. And so let's be real about what we're after here. Let's see, I skipped that. So, yeah, like was mentioned earlier, you need to make sure you know their past medical history and their other their conditions, their other medications. Do they need help? Have you assessed their age? Oh, this is a big one for me, the age. Well, by the way, this is why I think it's really the purview of primary care. I'm a family doctor, and I think this is where we have the greatest potential for impact. Yes, pain specialists are going to get into this. Yeah, other specialties, but really it's primary care where we could be the biggest positive influence on providing this for those who really need it and benefit from it, but also regulating it for those that may be harmed. Age. That's the big one, right? Being a regulatory system, down-regulating. We know that cannabis exposure, a lot of marijuana use with teenagers, very, very bad, right? It can down-regulate lots of neurotransmission, including cognitive development. That's the last thing we want to do is do that at their age. But they're also the most impulsive. They're also the most likely to experiment or want to use it or to be influenced by whatever source. So really, we've got to watch out. I don't worry about people over 30, 35, 40 asking for cannabis. I don't worry. Like they've had life experience. They have some condition. They don't want to get high and check out. They want to get back to their life. But I do worry about teenagers or 20-year-olds. They still think it's funny to check out for a while or to be under the influence. So yeah, taking a history of previous use and any addiction or abuse of any other substance is very, very important. And then setting expectations. Well, it depends, right? You talk about it. Because some of my best success has been with people addicted to opiates or chronic pain and went down that road. But now they're back to their life with cannabis therapy. In fact, I'll tell you a story. This is a great time for a story. So I'll tell you, there are two stories that I like to highlight. One is a gentleman, he's a carpenter. He came to work at our house. My wife, who's sitting right here, said, well, I got to know him, and he said, I need a doctor. Your husband's a doctor. Will he see me? She said, sure, no problem. So he comes, and great guy, great carpenter. But he tells me his story, and he says, well, he had an accident, injured, back pain, opiates, surgery, all of that, depression, lost his job, all of that. So he hits rock bottom, gets into heroin, all of that. Goes to rehab, turns his life around, bounces back, gets married, has a child, children, his own business as a carpenter. So I'm hearing this whole story in the office thinking, okay, I bet he's used cannabis somewhere, right? So I ask him, well, how are you dealing with your pain? I mean, have you ever used cannabis therapy? And his eyes just get really big. And he kind of pauses. And he's like, I didn't know I could talk about that here. And it was this moment. I'm like, yeah, this is where tell me about it. I actually do this. I can be a provider for that. How has cannabis helped you with your whole story? And he literally teared up. He literally teared up and he said, this is the only way I manage. It's the only way I can deal with my past and deal with that and function. And to think that I can sign off on a card for him, he literally cried. And I've had that repeated several times. Some people, it can really be a boon and it can really be their lifeline. But the point is, that's where we should talk about it. He didn't know that he could tell an MD in a clinic and be okay. So, second story. I see on my schedule, 17-year-old boy coming in. I can't remember if it said anxiety or if it said cannabis. I can't remember what it said on my on the schedule, but they come in. He comes in with mom, and here's his story. Well, he's been dealing with a lot of anxiety, 15, 16 years old. A friend gives him some marijuana. It helped. He liked it. Whatever, started using. His mom finds out about it, but mom's cool. Mom, well, I don't know when she found out about it. She's the one that brought him into me, but his friend says, why don't we get you your own card? Because you're obviously, need this. So they go to California. They drive to California, and they find a kiosk on a beach. And he registers or whatever they do. I don't know what they do. Comes back thinking that's going to work in Utah. It won't work in Utah. But mom finds out, brings him in. So I hear this story, and inside I'm just kind of crying or I'm screaming at the same time. No, this is not a good idea. You don't want to treat a 17-year-old male with cannabis for anxiety. That's only going to go worse. But what I was grateful for was mom knew to bring him in to me. I'm the family doctor. This is where we should talk about it. This is a safe place to talk about it. And that's what happened. We had a good discussion, and we tried to talk about other ways we could approach his anxiety and treat him rather than that. Because as you noticed from the indication list, did you notice the two glaring, the two things that were missing? Anxiety and insomnia. They're not on the list, and there are reasons for that. Big reasons for that. Those are Pandora's boxes, and it's not a good idea to. Now, insomnia, sleep is one of the biggest things that people come back and tell me when they have success with cannabis therapy. They say, "Oh, I feel my pain." They always come back and tell me if it's for chronic pain. They'll come back and say, "Look, I still have pain, but I can deal with it. I can manage it. I can cope. It takes the edge off, and I can sleep." Or every iteration of that phrase is what I hear. And they sleep better. And as you know, if you sleep better, everything gets a little bit better, right? If you fix someone's sleep, their whole life is better, even if it's not perfect. So it's kind of, for simplified purposes, it kind of treats secondary insomnia, right? They have insomnia because of pain or anxiety or whatever. It's really going to help with that. Primary insomnia, we looked at the research for primary legitimate insomnia, and cannabis didn't really perform any better than placebo or anything else. So that's the real reason why it's not on the list, because high-level quality research did not show an impact. But that's one of the most common benefits that people will come back and say. So it's got to be some secondary process. It's either, well, for what it's worth. So that's that second story with that youth, is we need to be that place where people can come for information, for guidance, for direction. not to a kiosk on a beach in California. Okay, nothing against California, but I just don't think that's where they should be going. Oh, good question. I remember from last year, right? We talked last year. But just what she said, they get better, and it kind of is attributable back to that endocannabinoid system. What is it about that they still have pain, but they do better? Their mood, their sleep, their initiative, their ability to cope, all of that gets better. So it kind of attributes back to that fact that we don't understand completely the endocannabinoid system and its reach. But you've seen it, and I've seen it. So they do better. On anxiety, well, that's difficult, right? Because anxiety is so multifactorial. How much anxiety is just their life's a catastrophe, right? That could be part of it, or some event, or there's coping skills, their strategies, their past. I mean, it's so complicated that I don't even know how to answer that question. I just know that it's a Pandora's box, and no state has approved, right? No state has approved anxiety as an indicator. Oh, have they? Okay. Yeah, right. So, and PTSD, related to anxiety, so it's really hard. And I think one of the reasons very few psychiatrists like cannabis therapy. Why? Because psychosis risk goes up. Right? So if someone has a history of psychosis, probably not a good idea to treat them with cannabis. You probably should avoid that. The benefits really don't seem to outweigh the risks if they have a propensity for psychosis. No, and so that's why mental health therapy or prescribers really haven't seen a lot of use for this, because they deal with so many other things, and with our conventional medicine, that's just hard to go there. But how many people report that they just feel calmer and they feel better? Many. So you'll have to navigate that with patients. Okay. Well, let's move on. I want to keep, so we have plenty of time. Education, we've made that point clear. It's really needs education, because think about it. When you prescribe other medicines, even hydrocodone, what have you got? You've got dose and you've got frequency. Well, with cannabis, you have dose and you've got frequency, but you also got the ratio, how much THC and how much CBD you're going to have. And then you've got the route. It does matter, the route. You know, a gummy takes an hour to 2 hours to kick in. A vape, 30 seconds, right? Or somewhere around there. It's really different depending on what you're treating. And then you've got the strain of the plant, which most are hybrid now, but the traditional ones are indica and sativa, and any hybrid thereafter. You know, indica is a bushier plant, comes from the Central Asia, and it's kind of more CBD rich, or it's kind of more calming. And there's a whole culture too, right? The subculture of cannabis. So they always say indica, that just means indicouch. So that's how you remember indica. It's indicouch. So it's very sativa. It's more from Mediterranean, warmer climates, African climates. So it's a thinner, more potent plant with more, I don't know if it's higher THC or it's just it's stimulating. So it does matter. In most plants these days, we're decades and decades of cultivation. We've got hybrids, but it probably matters less than they think it does, but it still does matter. They love to talk about it. It's part of the culture. But anyway, that's 5 variables, not 2. That's 5 variables. So yeah, when patients are going to the black market because it's cheaper, and if you're talking $15 to $30 cheaper, so you're only worth about $15 or $30. But that's what that's why they need to be educated. Please come and I can tell you how to do this properly. Because if you're going to go get some stuff from the black market, it's not what you need, and it's going to make things worse, and it could be contaminated. So again, I'll put a kudos to the Department of Health and the Department of Ag. At least three instances since I've been involved where the Department of Agriculture found something in testing, notified the Department of Health, notified the cultivators and the producers in Utah, and they made a change and made it go away. That vitamin OA acetate, what was it? The vitamin E O acetate. It accumulated when they let it sit on the weekend. It accumulated, and then it got into the products. And so so other states are not testing like we are. We are trying really hard to be a model for a safe cannabis program, and that's kudos to them. Okay, we talked about that. Strategies for safer use. So usually not first-line treatment, right? Because it's not a specific treatment. It's a generalized treatment, so not first-line. Screen patients. Do a big assessment, really see if you can understand where they're coming from. So some pitfalls. Bipolar disorder. So these are some conditions that don't respond well and you probably want to avoid. Bipolar, again, maybe not. It's bordering on that psychosis level. You're going to have more severe symptoms, more time in manic episodes, more psychotic system, depression. Probably not a great treatment for depression where you're kind of down-regulating things. Depression, we often need to up-regulate and kind of get them out of the couch, not in the couch. PTSD, again, this one's really difficult. You noticed from Rich's presentation, PTSD was the second, a distant second, but it was the second most common reason people reported use. We need more research in this area. This one's difficult, not only for the diagnostic side, because nowadays some people say, well, gosh, I must have PTSD because someone pulled my pants down at the pool when I was 12, or whatever. The term is now becoming so common in our common vernacular that people will use it for anything. We do need to be very specific about this diagnosis and then the treatment. Cannabis could be useful, but we still need higher level evidence for this or how to use it. A lot of the use is just self-directed. Anxiety. Back to anxiety. So I should have mentioned this earlier, but this is the other problem with that. At low doses, THC seems to relieve anxiety, but at high doses, it will trigger it. It will cause it. And how many patients that are self-diagnosing, self-regulating, or treating and managing their own dose are going to be reliable to keep the doses low? Not many, I would submit, because as anxiety grows or expands, they're more willing to dose more. They'll just keep dosing, and then they're going to trigger more. Okay, so this slide's one of my favorite ones, and I don't want to take too long, but this one's great. So talking about realistic, I love this study. So imagine a matrix of six categories where you've got high dose. Well, you've got these, let's see, is that 6 or 7 categories? Where you've got high THC products, balanced or high CBD products, and then you've got, actually it's just high THC and then more balanced. But then you've got 3 categories of, are they using rarely, or are they using about once a week to twice a week, or are they using every day? And just by prefacing that, what do you think is worse? So these are rates of psychosis. So look at this graph, and for you online, I don't know if the video they could see that, but all these categories, look at this category. And that category, where these are rates of psychosis induced by cannabis therapy. High THC every day. That's bad. All the other categories are, for all intents and purposes, almost equal. The only other one, the purple one that was high, well, that's just high THC with semi-regular use. But this slide is really telling. And like a lot of other treatments or drugs, you can get away with a lot. Your body will recover. Think about hormones or steroids. They're fine with intermittent use, but you use them every day, well, you're going to get a blood clot, or you're going to have immunosuppression, or you're going to have all sorts of other things. So that's kind of the message here. You don't want someone to use high-dose THC every single day. Well, who are those people? Pardon? Yeah. People treating or using recreationally, especially if they've got, well, the people who are using recreationally that might have undiagnosed or untreated anxiety or depression. Well, they feel good when they use it. And it's a slippery slope. Pretty soon they're using it every day with high THC because now they've got some tolerance. And that's who ends up with psychosis. How close, if they have a family history of psychosis, how close? That's a great question. That's beyond the scope of my, that's a great question though, because you would just wonder, with that family history, how close is it before they're a risk? I don't know. Pardon? With pain, it's a first-degree relative? Okay. Very good. So I love this slide because it really shows, because that's our job as clinicians, right? We really need to be the ones with the signposts or the warning flags to say, hey, this is where it's bad. This is where you can get away with it. This is where we can actually use it. This is where it's bad. When I said under 25, or was that listed? Yeah, that was just a sort of a best practice. And maybe that's more of my opinion. I mean, so the program, it's legal for 21 and older with a card. But like I say, under 25, I really hesitate. Like, you really got to convince me. Like, what is this going to do that we can't do some other way? Right. Yep. Yep. So our definition of adult, 18, 21, what is it? Well, we know that cognitive development, is still happening until 25, at least elasticity of the brain and all that stuff that we know. Anyway, but great question. This is the kind of things you should be thinking about when patients are asking you and you're thinking about it. Pregnancy, yeah, not a good idea. Some will still use it. I had a patient still used it because she had epilepsy but then got pregnant. Luckily, things turned out to be mostly okay. The baby was born with small for gestational age, very small for gestational age. She's doing better now. But some people will do what they want to do. But I would consider it, because it's not an FDA approved, we don't have like FDA contraindications, but I would clinically really consider that a contraindication. Cardiac conditions that are unstable, because yeah, you can stimulate heart rate and other things like that. Allergies, psychiatric diagnosis, again, the psychosis, and immunosuppression. Immunosuppression, there's some immunosuppressive activity with cannabis. I don't think it's a lot. Whenever we say immunosuppression, do we ever quantify that? We don't really. Like, how much immunosuppression do we get from cyclosporin versus prednisone? I don't know. It's just they're both immunosuppressants. I don't know how we quantify that. So I think it is there, but I don't know. I would guess it's a lot less than some of the other drugs we use. CDL holders. Yeah, right? Right. And concealed carry is also a question that comes up, because that's, that's part of a federal background check. But yeah, CDL, because well, you're driving commercially, not just personally. And if you're driving commercially, you're driving longer hours. And we said earlier, or maybe it's later, that you probably should wait 6 to 8 hours before driving on cannabis. In fact, I think that's a very important point to know. Okay, from the 80s, we have all the studies that were done for Marinol and dronabinol. So those, you've heard of those medicines. Those are synthetic THC developed in the later 80s. The only benefit to those is they did all the FDA testing to look at the cytochrome P450 system and to see if it interacted with any other drugs. They didn't interact with very many other drugs. So cannabis is really safe to use with most other drugs, except other central nervous system depressants, right? Mixing it with alcohol or any other central nervous system depressant, not a good idea. However, that is a common myth, right? It was assumed for decades that cannabis would suppress respiratory drive just like opiates and benzodiazepines. That is not the case. There aren't receptors for CBD receptors or for cannabis in the respiratory system of the brainstem. So it does not cause respiratory suppression, and you will not die in overdose. However, I would not mix it with other central nervous system depressants because you will amplify the drowsiness and the depression. Yeah, and the reason why Marinol and Sativex weren't that good is they were synthetic THC, but they were just THC only. Again, just like the endocannabinoid system is a sprawling, broad system, cannabis itself has hundreds of cannabinoids. Now, of the plant, when you break down the plant, about 40% of the plant's CBD. THC might make up 15 to 20 to 30% of the plant. Well, the other 30% is a smattering of 100 other cannabinoids. The next most common is CBG, and then all these others. And then you got terpenes and all the other things in the plant. So the concept of the entourage effect is what would account why products that are cultivated now and used with the whole oil are better than a synthetic THC. And again, that's where we need to study more about the entourage effect of having all those chemicals in a blend, and then its effect on the endocannabinoid system. Boy, that's a great question. So in case those online didn't hear, the question was about anticoagulants and if cannabis would interfere with specifically the novel anticoagulants. And I don't know. I think I read that, but I didn't investigate it. So I'm sorry I'm not prepared with that answer, but I would definitely look into that. My guess is it would be minor, but I would certainly check if your patient is in that situation. Great question. We talked about some of that. Yeah, so amphetamines and antidepressants could stimulate cardiac effects. So all these are important to take into consideration, which the patient's not going to if they're just getting information online, right? Or from a friend. There it is. It can increase INR with warfarin, but I didn't research the well. Everything interacts with warfarin. Is that a surprise to anyone, right? But I didn't research the DOAC. So that's a great question. Okay. Yeah, we talked about the ratios. Yeah. It's very important. I've had the most success with treating chronic pain with a balanced ratio. A gummy, 1 to 1 to 1, 1 part THC, 1 part CBD, and 1 part CBG. Or they make a gummy in St. George that's a 1:1 to 2. 1 part THC, 1 part CBD, 2 parts CBG. CBG has some anti-inflammatory properties. I don't know how much, but that combination seems to be, they really like it. Now, I consider two types of patients that I see with cannabis. Those that were already using before they came to me, and those that I got to start fresh. And they're both great for different reasons, but I really like the ones that we got to start fresh. They were naive to cannabis therapy, and that's the best, because then we can start this journey together. And those are some of my favorite patients, because we really started right, and they trust me, and they've had a positive experience. Some haven't, but it wasn't a negative experience. It just didn't work very well, but they didn't have a negative experience. But the vast majority have had a positive experience because we had good expectations. We started low. We start low and go slow, and we used appropriate products, and it's been very, very positive. We talked about regular use. 10% of adults using cannabis and 16% of children can develop cannabis use disorder. Another hint, hint, wink, wink, nudge, nudge on this one. That's an important stat to know for your but we don't want to develop cannabis use disorder. Is that right? I'm not exactly sure. That's the data that we had, but guess what leads to that? Daily use, high-dose THC. That's what's going to do that. If you really stick to the guidelines of, and again, we've tried to very hard at the Department of Health give guidance on the research that's available and what quality and level of research there is, and what we would recommend for dosing and for treatment. It's all on that website. 6 to 8 hours after using cannabis before driving. Driving under the influence is bad. Here's the problem in Utah. Have driving accidents under the influence gone up since 2018? Yes. Actually, since 2015, when it was either Nevada and or Colorado legalized it. Driving accidents have gone up steadily. Here's the problem. There's no field sobriety test for cannabis, right? Testing is unreliable. We don't have a way of testing and enforcing that other than education, right? Because even when people are not in their right mind, they still don't want to be in an accident. So we've got a lot of work to do to help educate our patients and the public. That was cannabis use disorder. Yeah. Mm-hmm. Yeah, I don't have a lot of the actual data on some of those things, but hyperemesis syndrome, yeah, I've had 3 patients develop that. They were not patients I started on cannabis, they were already using. But it's terrible. Right. So driving impaired. Yes, you can pick up THC levels in the urine or the blood. It's just, pardon? It's just not very reliable on the amounts. Like, what do you set as an amount? But the message is, don't drive impaired. So again, you set goals of therapy. Most of my patients just use this at night. Most chronic pain patients say, I can deal with my pain during the day. I just can't sleep. I just can't relax. I can't. And most of them just take it at night. I have very few who dose during the day from the ones I see. The question is there a ratio of THC, CBD, or CBG to try to reduce hyperemesis syndrome developing? I don't know, other than avoiding high-dose THC daily. I don't know. Again, if they're using a mixed ratio like that, an even ratio, at appropriate doses, I haven't had anybody have very many problems at all. Because if they're naive to cannabis, you give them a 1-to-1-to-1. They start at 2.5 milligrams, 5 milligrams. They're usually settle at 5. Rarely do they go above 10. Experienced users, oh, they're up to 20 milligrams or more of THC because they have tolerance. But they've usually used maybe excessively. The ones I've started, they settle at 5 milligrams, maybe 7.5 or 10. And that's kind of where they stay, because if they use more, they usually don't like it. You know, they usually, if you're chronic pain and you're 40 years old, or if you're 60-year-old with arthritis, and they took too much once and they felt high, they do not like it. It's not a great, well, I don't know personally, but it's not a great high. It's really not. That's a great question. So if they're on 5 milligrams of oxycodone twice a day for chronic pain, and, well, usually they're just asking if there's a way they can get off of that, or if it's not adequately treating their pain, or some other reason. If they're content the way they are, I don't know, but let's say they have liver problems or kidney problems, or they also supplement with ibuprofen, but then they've got stage 3 kidney disease. Well, there's a reason. Does that help? But this it kind of goes back to, you know your patients and you have a good open conversation, and really it's a lot easier than you think. So I'm going to kind of end with that. There's more just on, the rest of the slides are just on the difference between tinctures and gummies and vapes and all of that. But really, this is a great last slide. It's extremely individualized, right? And these are, like I said, some of my funnest patients, because they're grateful. They need help. They're grateful to get it. They've had positive experiences, but it is individualized. The method of delivery, the ratio, start low and go slow. But really, some of that's the easy part. The first part is why, when, and why are you treating? And what are your goals? That's where you start, because if that's done well, then everything else is easy. I tell the med students that I have in clinic, the medicine's the easy part. Family medicine, the medicine, I don't care if it's Lantus or Toujeo, I don't care. The medicine's the easy part. Getting people to change their behavior, getting people to take the medicine first or do other lifestyle changes, that's the hard part. But the more they trust you and the more they understand the disease process and the goals of therapy, the better that will be. And it's no different with this. And so, say the first part again. Pretty simple. You stop cannabis. That's it. I don't know. That's a great question. Before they stop, they see results from hyperemesis syndrome. I'm not sure. Usually they end up in the ER and they give them a bunch of Ativan to get them to quit puking. Then they come see you and you say, you're done. So another patient, a classic patient of mine, well, it's actually the husband of the one that had the small for gestational age baby. Treated his anxiety from age 19 to 29. Then developed cannabis hyperemesis syndrome. Well, now he's done. I got to say, you can't have any more. And he's doing fine. But that's where I wish to say, oh, who told you to treat your anxiety with cannabis at age 19? Bad idea. So, okay. Great question. Withdrawal from cannabis is not serious. So yeah, you can just stop it abruptly. Will they have some withdrawal? Yeah, you can withdraw from mostly anything, but cannabis withdrawal, again, because it's a system that doesn't have a direct function, it's not serious. They'll be uncomfortable. That's kind of what she asked too, but more of the acute. It takes all day. Like they're in the ER with Ativan. If it's bad enough. Oh, is that right? Was she treated in the ER first, or was this just a month at home? Yeah, terrible, right? So I don't like scare tactics. We know that scare tactics don't work. How many times have we tried that with nicotine and smoking? It doesn't work, but you don't hide the truth nevertheless. You want to tell, well, this is a real thing. There was a wake-up call. Awesome, thank you. Oh, $60 to $100. Yeah, for a month's supply of gummies or whatever they're buying, they're going to spend 60 to 100, maybe 50 to 100. If they buy stuff on sale, that's another good point, right? These dispensaries are highly regulated, and they pay a lot of fees to the state to be a dispensary, but they still have to make money, right? We still have this weird system in America where we have private, regulated, but private health care, and I'm not advocating for the state to just take over all the pharmacies, but it is going to influence the decisions on what they carry, and what they're going to price it at, and yeah, it's hard. But I hope that gives you an idea. Well, thank you all so much. You don't have to stay. We're done, but I'll keep talking if you want. Thank you so much.
What do you do to stay out of trouble with the DEA, the Board of Medicine, other regulatory agencies, or is it even a concern for you in the state of Utah?
I don't even think about it. Just document well. When they come in, that's why I love these conversations, because we just talk about the goals of therapy. I'm very honest, what it will and won't do, and they're honest. It's refreshing when they come in and say, I